I approach this in a way that I think is unconventional. I think it goes against the grain, probably. Focusing on number of goals mastered, even number of skills mastered is totally a distraction. It's missing the mark because what gets measured gets selected.
Hello, everyone. Welcome to ABA Business Leaders, brought to you by 3Pi Squared. I'm April.
And I'm Stephen.
And today we have with us a special guest, Bryant Silbaugh. He is the founder and CEO of NASQN, the National ABA Service Quality Network. He's a behavior analyst who specializes in the assessment and treatment of autism spectrum disorders. He has a book, Quality Control for Behavior Analysts, How to Manage Behavioral Intervention Quality in Autism Service Settings. And there's so much more about Bryant's experience in the field. And if you want to learn more about him, you can look at the bio in our show notes. But welcome, Bryant. Thanks for being here today.
Hi, Stephen and April. It's a real pleasure to be with y'all. And thank you for the opportunity.
Yeah, absolutely. So really, we're just going to jump in today. Our topic for today is quality. If you have been a listener for even a short time, then you'll know that that's something that we talk about a lot, is how important it is to provide quality services. And you may think, oh, well, that's a no-brainer. That's what we all want to do, right? That's what we're here for, is to help. And a lot of those of you listening, even started your own business because you wanted to be able to have more control in how you provide
better services, higher quality.
Right.
Yeah, we hear that very often.
Yeah, do things a little better than the place you worked at before. And so that brings us to our conversation where we often talk about, well, how do you know you're providing quality services? And, a lot of times we don't know.
Right.
And so, not only what does quality services, what do they look like? How do you know you're providing them? If you're not providing them, then, oh shoot, what do I do now? Right. So when we've had a conversation in the past with Bryant and learned more about NASQN and, been following his work and super excited about, what you guys are doing in the field. And so we invited Bryant on to have this conversation because I think he's the perfect guy for this conversation. So, thank you so much. And, I don't know, let's just jump in. What's quality, Bryant? How do you know?
I don't. Excellent question. And thank you for your kind words as well. I've been in the field for about 19 years or so, in various roles as an early childhood interventionist, what we would call like a behavior tech today. Before there was the RBT credential. And then I was working in homes in early childhood intervention and became a clinical supervisor. Got my BCBAs, after completing coursework at FIT, and eventually made my way back into grad school to get a PhD in special education and autism, and started a couple of research lines there, clinical research lines. And I carried that through to my role as an assistant professor at University of Texas at San Antonio around 2017. And around 2020, I realized I wasn't going to get tenure. And so I decided I'm going to, leave academia and get back into clinical practice. And around that time, I was consulting with a good friend and colleague, Rabiel Fatal at the time. And, we had a few meetings and started to narrow in on how I can be helpful and what our projects may be. And, at some point we jumped on a call. And he said, Bryant, how do you know if an ABA organization is delivering high quality services? He said, how do you know if it's a high quality company? How do you distinguish between varying degrees of quality as you're looking at different companies? And I thought that's a really good question because families want to know that. Families want to be able to differentiate between providers, ABA providers, in the same way they want to differentiate between childcare and school and plumbers and arborists and you name it, right? And so it was a great question. And I thought, I don't know. have no idea because I don't know. I just had never in graduate courses, even as a professor myself, I'm not sure I ever mentioned the word quality in anything that I ever taught, for cumulatively 8 years in different roles. And it's because the field in our peer-reviewed literature and our textbooks, they didn't really cover the topic of quality or quality assurance in the ABA service delivery. So that was a spark for Robbie and I to conduct some research on quality and answer that question for ourselves. What is quality?
That's great. Yeah, like in engineering, that's my background. Like quality is so important, right? Like having key performance indicators to make sure that our quality, our output is to the degree that we need it, and that, like you said, it's a struggle for the companies, but it's also super important for the clients. And when it's hard, like with a regular doctor, you can fill out a satisfaction survey and you can, right? But when you're working with children, right, it's really hard to say, okay, fill out this 20-page satisfaction survey and tell me how you feel about us, right? Like, so it's really hard to figure that out. And is that the only way to look at it anyway, right? What are those factors that we should be looking at? Is there like high level, do you have like some key metrics that you look at?
What you're talking about there is it's on an aspect of quality, which is a personally defined standard. Everyone has different standards. I don't know if that is the correct way to say everyone has different standards, but there's a variability in what people expect from a service, what good looks like. And so that's a nice segue into or I think we should look at that within the broader context of a framework for quality, so we can interpret that and look at quality from a variety of different angles. And at some point we will get to this KPI question of how does that fit into monitoring attainment of standards within a quality assurance framework. When Robbie, as I was mentioned, when Robbie and I launched some research, it ultimately resulted in a paper published in, I think it's 2022, in the Behavior Analysis in Practice. And I forget the actual title of our paper, but it was Exploring Quality in the ABA Service Industry, something like this. And what we wanted to do is sample from sources in ABA research and ABA practice how behavior analysts are talking about or conceptualize quality. So we could sort of start a conversation about, well, hey, there's considerable variability in how we talk about quality. Quality actually is underrepresented in research in our peer-reviewed journals. And so probably a lack of consensus on a definition of quality and an ability to operationally define quality is a barrier to the industry being able to objectively and verifiably sort of monitor quality over time and manipulate or design, I would say this way, design service delivery systems that enable clinicians, clinical directors, operators to engage in those practices necessary to meet standards and deliver and understand the variables. What are the variables that are influencing quality service practices? So that now, because we didn't have an evidence base. There wasn't there's a huge evidence base for 70 years building on the validation of behavior change procedures and assessments, but very little research validating the systems and the context that support practitioners using those validated procedures and assessments over time, to the satisfaction of other people based on their personally defined standards, So now I'll go back up a little bit. Okay. So in the paper, we said this, okay, here's a starting point. You can define quality, at least at the organizational level, as the extent to which an ABA organization meets professional and consumer standards over time in response to a receiving system. This is the recognition that there are external factors and contingencies in a macro system or a market that have an influence on what we do in any given organization. And then attaining those standards over time while surviving challenges in the marketplace to keep your organization thriving, but also maximize financial health over time. And the focus on that is really about the ability to continue to invest in quality assurance over time. It's not about the biggest profit. Sometimes when I first published that paper with Robbie and I started giving talks, they're like, why is this tied to profit and whatnot? And I was like, wait a minute, that's not the point here. Actually, we're talking broadly financial health is you have a healthy profit margin and a healthy, stable revenue streams, and you have a responsible growth over time in the investment in quality assurance. So you have operational goals and you have clinical quality goals, and both of them are receiving investment and attention, and they go together instead of one shooting off.
Yes.
And you have rapid, uncontrolled, sort of unreasonable growth in operations while quality lags behind. So that's been a starting point, and that's been sort of an anchor for everything that I've done in quality in sort of research and practice since.
Yeah, I like how you say like the company has to be sustainable. Like there has to be some profit in the company so you can reinvest. And so like what I assume, like you said, when you started talking about this, there was some pushback. Whoa. Like we had to focus on quality clinical services. Why are you bringing up profitability of my company in this, right? Like that's evil. That's bad. Can you talk more about that?
Yeah. I will say that I'm not a finance guy. I'm not a financial health of the organization is not my expertise. My expertise is more focused on designing the systems and the processes within a quality assurance system. And one of the things I'm learning is that it is difficult to draw a direct line between, let's say, like quality assurance initiatives or quality improvement initiatives and key business results from a financial perspective. It's tough because what I found is if you have a robust quality assurance system, like a quality management system that is developing across your organization, it happens as a result of everyone starting to feel like quality is everyone's job. Everyone has a role. Everyone plays a part. And no matter where you are in the organizational chart, you do have influence on service quality, especially with respect to what's exactly right in front of you. There are constraints the systems place on you, but you do have control over the quality of your interactions with other people and the outcomes or the work outputs of whatever your responsibilities or tasks are. You have a degree of control, and we can it'd be fun to talk, like double click on this later. But in the quality field, there are fundamental principles of managing for quality that anyone, anywhere in an organization can apply at any time to everything that they do. So I think that's a useful concept to apply. But yeah, you end up having, to build a quality assurance system, you end up having quality improvement initiatives that focus on often process improvement. And that happens through cross-functional teams where you have meaning people from different departments. In order to improve, for example, a training process in an ABA organization, you may have to work with the training team, but the clinicians who are the recipients of the trained technicians, but also the clinical director, and then HR and recruiting and people from other departments, operations, because everybody has a different perspective. And also, like there's this general underlying philosophy in quality, in the quality field outside of ABA, that everyone's a customer. Your client is not a customer. They are a customer. And if you are training technicians in your organization, the receiving system, the service delivery system where they go out of training and into direct treatment with clients in maybe a two-tiered model supervised by BCBAs, those BCBA supervisors, they're customers. They're receiving an output from a process and expecting they have a standard.
Right.
The organization has a standard, maybe. And then the clinician has a standard for what they need to get their job done. And the technician has a standard.
Like if you were talking to a smaller or ABA organization, like where would you recommend we start to measure that or to define our process?
In my role as founder and CEO of NASQN, National ABA Service Quality Network, I have a great team. I'm lucky to work with people that get my brain going, get my creativity going, ask me the right questions, and help me develop things, models, frameworks, concepts, ideas, things that make quality easier to communicate. Tailor communication about quality to different audiences. That's really important, because if you're talking with someone, let's say a VP of whatever in an organization that's in 20 states and they have thousands of employees, they're in a total different world than someone who's an entrepreneur and works with a couple of BCBAs and is a year or two into business or whatever, Right. And then there's everything in between. So one of the things that we've developed, and it is in, I would say, an earliest stage, and it will continue to develop, is something we call a quality maturity model. And you can think of it as breaking down the development of quality assurance practices in an ABA organization over time. And we've conceptualized it as consisting of 5 levels. So the 5 levels are really, I'll sort of talk a little bit about what they are. I'm curious what your thoughts are on this. So think of level 1 as an ABA organization that doesn't really have a clear definition of quality. Okay, the supervision practices and supervision quality vary widely, but it's not noticed or recognized or quantified in any clear way because there aren't systems or processes in place. You may be a startup and you may not even have a handbook, and you've just gone for it. And so now you've hired clinical supervisors and you don't have any real way to standardize what they're doing, evaluate what they're doing objectively, develop them professionally, determine the quality of the protocol modification sessions they're conducting, things like this. Okay. So we'll say there's variability in supervision in that organization. A lot of this key decisions by the organization, by leadership, by the supervisor, by employees is made maybe by more perception, intuition, less data driven. No, there may not be much data. Especially organizational or operational data. But they think they're doing well. You have to sort of tell yourself that every day.
Yes.
You know what I'm saying? So you can get up the hill. You're climbing the hill and giving everything you got to try to survive and build something that you, to your point earlier, Stephen, is people start, I believe most behavior analysts start a company because they're there must be a better way to do this. Maybe I can do it. Or maybe I can attract the right people who can build something better. That means they're going right into it with a continuous improvement mindset. And that's a key ingredient in quality. So that's actually a great starting point. Okay. So they get into this, but the contingencies that are really influential in quality or operations, service delivery, are things like time, billing, trying to survive. That's the dominating sort of mode. But there's high variability and poor outcomes. Poor clinical outcomes are actually hidden. They are happening. Maybe they're not hidden, but the outcomes aren't going to be great. Now, let's say they move to level 2. So level 2, they become more compliance driven. So this is an organization that's has the budget and the wherewithal to now invite an external auditor. Go ahead and pursue accreditation, or at least start exploring it. And so that they can start to look outside for what are standards of practice. Where's the bar? What does good look like according to another organization outside? And maybe they can help shape us, build us, hold us accountable, So now external standards dominate the concept of quality in the organization. It's all about compliance, meeting someone else's standards, another industry standards. And they're really trying to avoid errors, avoid clawbacks from audits, things like that. But the limitation here is that compliance is treated as equivalent to quality, but it isn't. It isn't quality. It's something else. And they won't have an internal system that drives improvements in processes outside of doing what they can to survive to get to the next month. Okay. So then in level 3, they define quality. So the way we think about this at NASQN is they may have stumbled upon the ASDQ paper from me and Robbie back in 2022, and they're like, oh shoot, there is a way to define quality. Okay. Or maybe they go to NASQN's website and they're scrolling down, they're like, fit for purpose. That's interesting. What does that mean? Well, that's a definition of quality from other industries. And now the organization for themselves starts to say, we have enough bandwidth and we're mature enough and developed enough that we can start defining quality. And then they start tracking supervision, quality, treatment, fidelity, outcomes, things like this. So there's a shift. I would say there's a developmental shift in the organization too. We define quality internally now. Now they're past some accreditation organization defining it for them. Now they're over that hump. They're looking at some research and they're saying, what's quality mean to us? Let's define it now. Level 4, and I'm almost there. There's 5 levels.
No. Yeah.
All right. So level 4 is now there's a quality assurance system that is developing. It's active. There's quality planning and quality control. There's KPIs. Now we're to KPIs, Stephen. It probably should have been some KPIs earlier, but there's a more robust sort of system of KPIs attached to the organization. Now understands how to break up their processes in ways throughout the system to identify the right meaningful KPIs, track them for the purpose of meeting standards. Supervision becomes more supervision practices, protocol modification, things like this, parent treatment guidance becomes more standardized. Variability in practices are reduced, and reinforcement begins to be tied to quality metrics. People roll out scorecards and other contingencies for quality service practices. Outcomes become more predictable. There's continuous improvement. Level 5 is an optimizing system. So there's continuous improvement beyond standards. They may even have realized now that cultural selection is a phenomenon influencing what their organization does, and maybe look through a meta contingency lens. Now the leadership is very much system and focus level. And what have we engineered? What are external forces causing us to do? How does that all work? Then they start to select for high quality culture. A culture is now evolving around clearly defined definitions of quality and metrics, processes, standardization. Now they have more market differentiation. They discover, hey, now we can differentiate ourselves from other providers because we have objectable, verifiable metrics of quality service practices. Their workforce becomes more stable. Maybe turnover goes down, burnout goes down, the quality of the applicants start increasing because word gets out. These folks know what they're doing. And then they start delivering better client outcomes, or at the very least get better at trying to quantify it and strategically allocate resources to objectively improve outcomes.
Yeah.
There's so much that I want to say, but I do want to let our listeners be able to sit in that, because I think that sometimes just knowing what that developmental process is. I love that term for it, because, especially as a lot of behavior analysts, like working in early intervention, that's something that we really focus on. Like when we're doing our programming for our learners, right, is developmental appropriateness for what we're working on. So if we can understand what a developmental, track might look like for an ABA company, it helps you to not feel so alone, and that's part of what we do here, right? And it kind of helps you to start learning some of those things that you don't know what you don't know. It kind of brings those to the forefront of, okay, these are the things I can start looking to. And you know what? It's okay if you're not at level 5 day 1 of opening your business.
All right. Yes.
Because I think sometimes we fall in, it's just as humans, right? What was it? Level 1, right? Just trying to survive, right? And you're just trying to keep those doors open, one foot in front of the other. And sometimes, what we see a lot of times are business owners who get stuck in level 1, right? And they don't know how to even move into level 2, because now we've turned into, a complete system of putting out fires one after the other. And when you're in that spot, it's hard to see outside of that. You feel like you don't have time to put anything in place, right? We work with people who, they're somewhere between level 3 and level 4, and they're really striving for level 5, right? And And yet they see, oh man, I was stuck in level 1 for so long. Great. Like if I could have done all of these things I'm doing now, then like, wow, we could have made even more of a difference. And so anyway, so having these levels and the definitions of these levels really for me is helping me to put all of these stories kind of within. It brings everything together, right?
Yeah. And I think like for me, it goes back to that vision, mission statement, understanding what it is that you want to build. When you open the door, what do you hear? You know, what does therapy look like to you, and really having a good understanding of what it is you're trying to build. Super important, because I think that for a lot of level 1s and level maybe 1.5s that I work with, it's like I know what quality is. I like, what did you write it down? Do you have definitions? No, I just know it when I see it. And then they, you know, start building from 10 employees to 20 employees to 30 employees to 40. And that's where we lose it, right? It's when I start to scale this and I can no longer micromanage every piece of this, that's where I'm finding my quality goes down. Stephen, what's going on? And so it is because, right, you haven't defined it. You don't know what this should look like. And so having those clear levels can help. And yeah. So, and then I do have one other question. I have a lot of questions, especially around KPI, but like, do you think it's a fair assumption to make if I have higher like if my staff are more educated, so maybe they're bachelor's degrees, master's degrees, doctorates, and I have a better standard of supervision and I have more training for my staff, that I can say I have a higher quality of services? Is that a good starting point, or am I completely ignorant? Does that make sense?
Well, definitely not completely ignorant. I'll just say it depends. Okay, it depends on. I'll give some more context here. I'll give some more context. So I think it would be helpful to put that question in like a simple framework with a couple of what I call like triads or heuristics. You know, for the ABA service delivery quality framework, from the Silbaugh and Fatal paper I mentioned, based on that definition of quality I gave, you can look at that as a triad. There's professional standards, consumer standards, financial health. That's the aim. So the question, I really look through this through that lens. And so I'd say, okay, given those conditions that you just described, to what extent are professional and consumer standards being attained in different processes in the organization? So for example, like, an organization can set standards for what good looks like in a direct treatment session, a 97153, reimbursed session. But also they can set separate standards for what is a good protocol modification session. What is a good parent treatment guidance session? What does it look like when a clinical director is doing a good job in their clinic? And so on and so forth. What does good recruitment look like? What does good scheduling look like? Right. So each of these are different processes that have different standards. And you know what? You could have, a service delivery system where you have a PhD, with 15 years of experience. They've published research. They're a master clinician. And you have no standards. Right. Or you have standards for protocol modification sessions, and they're unattainable because you've designed, unfortunately, or there's the lack thereof of the design of the service delivery system or the process of protocol modification, or it can be scheduling, it can be staffing, it can be case assignment, where you've thrown competing contingencies at that master clinician that will not let them do their job. And right. That's I hear, like, maybe just because I spend too much time on LinkedIn, but I hear a lot of chatter about like, master clinicians leave, not because they haven't fallen. It's not that they've fallen out of love of the work. They love the work. It's part of their life, really. If you're a clinician that long, I know as someone who's in clinical practice to some varying extent for 19 years, it becomes a part of your life, in a big way. Mm-hmm. And so the love of the work doesn't go away. is that you realize you get so good at evaluating whether you're having a meaningful impact and your interventions are responsible for improving the client outcomes, that you start to realize, I'm stuck in systems that won't let me, that system doesn't know that what it's forcing me to do doesn't work, and actually squeezes out real ABA from protocol mod sessions and FBAs and all the things. So I don't know. I went all down a rabbit hole, but I said I was going to give you a framework and some heuristics. So let's go back to that. Okay.
Sounds good.
So there's the professional standards, consumer standards, financial health. We'll call that ASDQ framework. Now, there's back in the 80s, there was a quality pioneer, Joseph Duran, and I like to call him the Skinner of quality, to give behavior analysts an appreciation for like who he is in that field. Okay, so he's the Skinner of quality. And he wrote a paper on something called the Quality Trilogy, or the Duran Trilogy. I think the paper was like Fundamental Principles for Managing for Quality. I always forget. But it was in the 80s, and he was calling out American industries is in need of improvement in the quality of products and services. And his approach was, well, we have to completely transform what management looks like in American industries. And the way to do that effectively is to apply principles of managing for quality that can be universally and generally applicable anywhere, anytime, by any manager in any industry, regardless of the product or service. So if it's, so in the quality trilogy is quality planning, quality control, and quality improvement. And that's the trilogy. And so you can, as an organization, if you're level 1, 2, 3, 4, 5, doesn't matter. If you're the CEO, if you're a clinical director, if you're a technician, if you're an HR representative, doesn't matter who you are. If you are at work, you can plan for the quality of whatever work you're going to do. You can control it by taking, so really quality planning means that you have put in a plan for what you, or a process or a system or a procedure will look like in operations and what the outcomes will be. Okay, so I can plan a protocol modification session and say, in this 3:00 session in home with this client for 2 hours, I'm going to do visual analysis on skill acquisition and a behavior reduction target. I'm going to assess fidelity on at least one skill acquisition target. I'm going to complete a paired stimulus preference assessment I started in the last protocol mod session. I'm going to help that technician prompt fade on a particular target. And I'm going to check in with the parent on our next parent treatment guidance session and get that scheduled. I have a plan. That's the elements of my plan. So now I can go into my protocol mod session. And if I have my plan, presumably it's written out, not on my hand. It's written out on an Excel spreadsheet, or in what NASQN has developed, the Behavior Analyst Companion, which we could jump into, a tool that lets you do this. I can now self-monitor over the 2-hour period. Am I implementing my plan? Okay. And then at the end of supervision, I can say, if I implemented the plan, I've engaged in quality control. If I said I was going to do 5 things, I did those 5 things, then the outcome is the plan are the same. It's the same as if you get a recipe for a cake. Yep. And you follow the recipe and you bake the cake, comes out as expected, quality control. That's a high quality cake. It's a high quality cake, not because it met the plan though. It's a high quality cake, or this is a high quality protocol modification session, because the person eating the cake, or the person who set out to bake the cake and has a personally defined standard for what that cake should look like, and the technician and the client who are the recipients of the planned actions from the protocol modification session, if they are satisfied with what just happened, now you have high quality. And so there I distinguish between quality control and the qualitative nature of quality. The qualitative nature, low, medium, high, and again, is determined by the stakeholders, the consumers, the personally defined set of standards attainment. Quality control is about, did you implement your plan as intended? Quality improvement is you identify barriers. You identify, in fact, when the plan is inadequate. Even though you're meeting the plan, there's waste in your process. There's waste in your procedure. There's errors that are made. So you take proactive steps going forward to eliminate that waste, eliminate those errors. That's quality improvement. So literally anybody can apply that trilogy anywhere, anytime.
Yeah. And that also touches on what you're like, let's double click on this. The quality is everyone's job. It really puts it shows what you mean by that, right?
It's, I find this very similar to the board ethic, right? And kind of going to accreditation, right? Like you can follow somebody else's standard, but that's different than you using your own ethic and growing with that, because like the accreditation can get you so far, the board ethic can get you so far, but if you don't have your own understanding of how you're going to put this in practice, I think that we go back and I see it on Facebook. That's not ethical. Well, like, all of these little posts that I see online, it's like, I need a lot more information than that, 3-sentence, is this ethical or not? Right. And so I think that is very similar to when you're starting your business. Right. Does that make sense? Yeah.
Yeah, I followed. But I'm your wife, so.
And then, just going into KPI really briefly, because we could, talk about any of these sections, and I'm sure that you do, for hours and hours. When I'm coaching someone on starting KPI, like I preface it with, like, this can be used against you very quickly, right? If you get lost in the numbers, and our complete focus is on, okay, we have to be between, X and Y. And that's how we know this is quality. Things can get manipulated and we get lost in that number and not in the actual intention behind what we're measuring. And, especially if you're providing incentives for these measures. Do you have any feedback on that? How to prevent that? An example that I'll often use is like skill acquisition, right? Like you could have one BCBA that they're like two BCBAs doing very similar tasks, and I am not a BCBA, so how I'm gonna say this is probably terrible. But you have one BCBA that has like a goal, and they broke it down into 10 steps, 10 skills. And then you have another BCBA that has broken this down into 25 skills, because they know the more skills that this child acquires, the more incentive I get at the end of the day, right? Mm-hmm. And so, like, it's just really important that we understand what we're measuring, right? Like, so that we don't have that unintended effect, right? The other thing that I have seen, and then you guys can take it where you want to go, is, we're wanting to make sure that we have a high level of skill acquisition. So we're going to, during our intake process, we're going to maybe weed out some of the kids that we think, I don't know, I'm not sure I could get enough skill development here to meet my bonus this 6 months. So I'm going to recommend that we refer this child out. Do you know what I mean? And so that's my concern when you start. If you don't understand what can happen with KPI, that these things could unintentionally just happen over time.
I'm hearing that, like, hey, okay, so let's say you, in this particular scenario, an organization wants to, with the best of intentions, they want to improve clinical quality and outcomes for their patients or their clients. So they arrange let's say I'll just make this a financial contingency for the, for some measure of skill acquisition, goals met per unit of time or something like this, tied to number of the rate of skill acquisition as indicated by goal mastery or something in it. Okay. Mm-hmm. And so to your excellent point is that, I can take a complex goal that would take 3 months to master and break it down into 10 simpler goals that can be mastered at a higher rate. Or literally someone can take a gross motor imitation goal where the child's to master, 10 different gross motor actions imitated, like clap hands, arms up, arms out, touch nose, touch tummy, stomp feet, and all these things. And literally to treat each one as a goal. And and so actually, I'm used to treating that whole thing as a goal. Okay, you got to meet 10 targets, and then a goal is met. But if there isn't, and there isn't standardization in the field of how that's done, and so that explains there's variability in that KPI, if you will, to those like ways to game this. I don't know if gaming this is the right way to say it, but it's just like different ways to approach the problem of increasing the rate of goals mastered, that metric. Right. Yeah. Which is, I think that was your point, was like, it's not getting the point. Like, this isn't about that number. It's about, is that child's repertoire increasing faster? Are they benefiting? Okay.
Yeah. Do they have a better quality of life? Right. Yes.
Okay. So here's the deal. I approach this in a way that I think is unconventional. I think it goes against the grain probably. And I'll say this, that I think it's probably focusing on number of goals mastered, even number of skills mastered is totally a distraction. It's missing the mark. It's missing the mark because, I'll say it this way. What gets measured, I think I've said this before, what gets measured gets selected. And so, but I learned this from Jose Martinez Diaz, who was a really an inspiration to me and a mentor at FIT, who has since passed away. And in one of his lectures, he talked about you got to be really careful with permanent product as a measure. Like if you're measuring aggression let's just say you're measuring property destruction as the occurrence of new crayon markings on the wall or something like that.
Right.
Well, if there's more than one kid in the house, you don't know who marked that wall, kind of thing. Sure. Okay. And then, and you don't know the circumstance, you don't know the behavior. And so you want to be careful if you are going to measure results of behavior and tie contingencies to it. You have to be very careful of unwanted effects on behavior that produces the result, or this kind of thing. So here's a thought, okay, and I'll tie this to like CPT codes, 97155, for example. It doesn't matter. CPT codes, ABA companies who have insurance contracts getting reimbursed by Medicaid, we're billing by units of time, 15 minutes at a time, right? And so the contingency there influences everything that practitioners do. It's going to influence the KPIs that the organization selects and so forth. And so really what behavior analysts get paid for is time with patients. If you take that contingency real literally. And then there's the hope that what happens during that time is the evidence-based practice of ABA with outcomes that are planned, that the planned outcomes that are happening during protocol mod or drug treatment sessions are the actual outcomes that happen. Sometimes this focus on outcomes, really like this conversation on outcomes in ABA is focused on every 6 months as a reassessment of norm references, standardized assessments. And you want to see differences between the administrations, the results of those administrations. Well, that outcome is like, it's gone. Like the whole 6 months is gone once you assess that, and a focus on those outcomes. And that might even be the time where an organization looks at, okay, how many goals were mastered in that care cycle or service period. I got to say, I really feel like it's irrelevant, because what really matters is the point of contact of care during each 15-minute unit. And really, it's like hour, 2 hour, 3 hour supervision sessions or direct treatment sessions. What is happening in the interaction between the practitioner and the client or the consumer? What's happening? What is the exchange of reinforcement between them? How often does that happen? And what are the results in terms of the client's behavior as a result of the exchange of reinforcement between therapist, if you will, or technician, and the client? And so that's why I say that KPI isn't meaningful. I say what's a meaningful KPI is what was planned for the session to happen in the session, not cumulatively 6 months later. Now, they're with you now, and they need you now. We need an outcome now. You don't go to the dentist. When you go to the dentist to get a root canal, you get the root canal and then you go home, or you get the cavity filling, and you go home, right? Because there's an outcome that is expected as a result of that healthcare practice they're engaging in during that time with you in the chair. Well, similarly in ABA, we have to, I believe, from the quality assurance perspective, to systematically improve quality over time and with a focus on outcomes. You got to get at the point of contact of care right there and measure, what did the behavior analyst do in the last 5 or 10 minutes that resulted in an improvement in antecedent stimulus control over the client's behavior, or response differentiation enabled them to say a new word? What happened now, right now, that they enabled that? Okay, what enabled now for them to go longer without engaging in SIB so that they could participate in a few more skill acquisition trials? Did you plan to engage in a preference assessment to identify a preferred stimulus? And as a result of that process, that supervision process during your protocol mod session, did you identify a preferred stimulus? That outcome has a great deal of value to the client. They don't know it yet, but it does, because if you have a preferred stimulus for that client individualized to them, now you can do a reinforcer assessment and test, does that produce learning now? Not over 3 weeks, 4 weeks cumulative. No. Now. Does it work now? So I know I'm emphasizing that maybe a little dramatically. But I think if you have KPIs that are tied to outcomes at the point of contact of care, you don't need a quality assurance system wrapped around your whole organization to deliver high quality services. You can start right there.
I love that. I love that so much. Going back to the quality is everyone's job too. Like, we've had conversations on here before with other leaders in the field talking about understanding your own self-awareness and self-assessment as a behavior analyst, as a clinician, as a tech,
I completely agree with you that would be, but how do you put that in practice? So BCBA says, I've done the assessment on this child, right? And I have a plan of how I'm going to train my staff, right? Like how often we're going out there.
And now, what would that look like?
Right. But yeah. So how often, because how often am I readjusting my expected outcome in my session? How often should my RBT also be reevaluating? How do I even put that into practice in my company, right? Because like you said, I'm trying to survive here, right? And that sounds like a lot. So how would you do that? I'm curious.
I would propose, gosh, it ain't as hard as it sounds, and it ain't okay. All right. And I'll try to give you a simplified model of how anyone anywhere can get started this right after this podcast, after listening to this. Okay.
Great.
And I want to touch just briefly on what I think April was going with, and correct me if I'm wrong, but I think, April, you were starting to get sort of in the area or wheelhouse of, being sensitive to, or being mindful as an employee, that everyone around you is a customer, and you're at their service, and they have different perspectives on your performance, what you're delivering, and what good looks like. And there's a milieu there. You gotta, so that's important for delivering high quality services, is knowing that, like, the client has an expectation, the supervisor has an expectation, the director has an expectation, the parent, they're all your customers, and you're delivering a service when you're in the room running discrete trials or PRT or incidental teaching, chain all things. So I don't know if I touched on that, but
yeah, for sure. Yeah, you kind of help bring that together. Yeah, right. Just kind of looking at the bigger picture and how things are working together with that perspective. Yeah,
it's, if you're at the bottom of the ladder, at the bottom of the organization, you really can't see a whole lot past what you're doing in the day to day in your direct treatment sessions, and that can be hard to look beyond. But to your question, Stephen, about okay, so how do we let's simplify some of this complexity of what Bryant just said, and or any of this, and how do we put something into action, So, it's an excellent question. So I would suggest audiences or listeners think about this as establishing a self-management practice. It's, as a clinician, how are you going to manage what you do and your vital few? Let's call it your vital few. Every day you wake up, you go to work, you've got 1,000 things to do. Well, no, you don't. Forget that. You've got to narrow down your day down to a vital few. Okay. And that's the way everyone deals with complexity. And you realize that as you get older and you fail more and you have some successes, and then you realize, oh my gosh, like I really don't do anything. If I do anything in the day as a successful person in a career, I do 2 or 3 good things a day if I'm lucky. Yeah. You know what I'm saying?
Yeah.
So of value.
Sometimes one.
Sometimes
like I'm getting old now, I feel. So anyways, that's where that comes from. But yeah, a vital few. Okay. And so it's like, I'm going to go into today, I'm going to do protocol mod sessions on my cases. And I'm not going to do all the things. They all have like 40 programs, or whatever. And I've got 8 to 12 clients or whatever. No. You're going to see a couple clients today. A vital few can be like, I'm going to systematically self-manage myself. That's a vital few. You've got to do it. To deal with the complexity and the competing contingencies and the stress and the pressure and all the things going on in your life, you have to have a plan to self-manage and accomplish 2 other things. So one is I'm going to deliver a meaningful outcome to my clients and the clients that I see today and the technicians working with them, or the parents that I'm going to be coaching today. One meaningful outcome. Don't get crazy with it and overdo it. It's one meaningful outcome, but very specifically that you can tied to your interventions or your assessments, causal evidence, irrefutable, objective, verifiable evidence that you did something that produced an outcome that someone else wanted and expected as a result of receiving ABA services. And then I would say the third vital few is you better celebrate at the end of the day.
Right.
Okay. You take all that BS that you had to deal with all day to get your 2 things right today. And then you can still breathe and walk at the end of the day. You better celebrate that you got through it, you know? So that's important. So I say, have a self-management plan to deliver a meaningful outcome from your stakeholders' perspective for each person you're going to serve that day, and then celebrate it. So then the next question will probably be like, okay, what does self-management look like? Mm-hmm. Well, the cool thing is that I think technology is a major answer to how do you do that. And old school would have been like, bring a notepad. That's 20 years ago. Okay. And write your plan down in your notes. And then keep track of your progress throughout the day on your notepad. That's old school. Then we have technology, Excel spreadsheets or whatever, right? Okay. And now I think the next generation of tools for practitioners of ABA to self-manage and monitor, deliver, improve their outcomes that they're providing others over time are apps. You need something in your hand because that freaking phone is glued to you for the rest of your life. It's always with you. Okay. You're very good at going boop, 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 and navigating to things, and apps are made to be user friendly now. So at NASQN, we've developed the Behavior Analyst Companion app, and it's meant to do exactly this. It's extremely simple, where it enables you to monitor your stress, to check in with yourself, to maybe take one action a day to care for yourself, whatever that may be as defined by you. And then to gain insight into other users of the app. How are they feeling about particular aspects of the experience of being a behavior analyst? And then also to celebrate. So in the app, it's like this. It's 30 seconds. You open it up. It's free, by the way. And at the beginning of the day, you can open the app and it's going to ask you to rate from 1 to 5 your stress, and your energy, and your caseload or workload pressure, depending if you're a clinician or not a clinician. And boop, boop, boop takes 10 seconds. Then it's going to populate and show you a graph over time, days, weeks, months, quarters, of how your stress and your caseload pressure, workload pressure has been varying over time. And if it starts to dip or trend in the negative direction, you'll get prompts on the app, and it'll give you suggestions for how you might take a moment. Like, for example, put your devices down and for 30 seconds, close your eyes and think about one big reason why you got into this field and why you're doing this work, and reconnect with your passion, what meant everything to you, and why you're doing this. Now, the cool thing about this, I don't know if people are using the app that way, but that's what my vision is. After you reflect, you track on the app and you say, yep, I did it. And then you go to your wins. And that's where you should visit. At the end of the day, you reflect on wins. What did I accomplish today? I should log 1 or 2. So I celebrate, because you got to keep, just like with our clients, if it takes 3 months for a kid to learn how to match 3D identical objects, and you can attribute it to that intervention. Dude, those 3 months were hard, but you're freaking floored when they can freaking match independently. And you're like, hallelujah, we have a breakthrough and now we can do more. And it was all freaking worth it, right? So we're already conditioned to celebrate small wins for others. So I think an app like this can help you celebrate small wins for yourself that you need to focus on. You are accomplishing your vital few. And then the last step of it is like there's a supervision feature. In the supervision feature, you literally can click a button that says plan session. And then you can check boxes that say, I'm going to do FA today. I'm going to do fidelity assessment. I'm going to write a new protocol. I'm going to do protocol mod. I'm going to do this. I'm going to train the staff. Click 90-minute session. Click start. There's no client identifying information. It's private. It's yours. Okay. And then you start your session and there's your self-monitoring thing. You just check the boxes as you deliver the outcomes from those processes. Click another button. You get a graph that shows you the percentage of your planned outcomes that you've been delivering over time. And now you can track it. Even better, down below, there's something we call a supervision value calculator. In value-based care, the basic formula is outcomes over cost, right? It's like, what can you deliver to your patient over the unit of time in a care cycle? That equals value. So we just converted that to a protocol mod session, and we look at the point of contact of care, the outcomes that you're delivering right there for your client using evidence-based ABA. How many are you delivering in the amount of time that you're supervising? There's the value. And so that's data that you can use to then self-manage and improve over time. And that, I think that's an easy way to start. You don't have to be all sophisticated. You can say, I'm going to plan one thing, by law. Or in order to do a protocol mod session, you got a protocol mod. So click that button, start there.
Oh, I love that so much. And I think that, I know this sounds goofy, but like kind of made my brain happy because this self-management practice, like the vital few and like pulling it together, it really helped like where I was trying to go with, okay, well, we're all responsible, right? We all have some control over like quality, each person. Yet there's this level of like ownership and like self understanding ourself and being self-awareness, that piece, right? And then Steven's like, okay, well, what's the next small step? Well, it just all brought it all together. I love that. I'm so excited about this app and even just the way of looking at it, just a self-management practice of how to go in, looking at it and helping, because also I think it's important too, even a part of this is important is the planning piece too, because I know that's one thing that we can get really swept up and life gets busy and we pop into a session and then we're like, okay, where are we doing? Who's
what's
what?
Your name?
And then you spend a bit of time either listening to the tech, like asking questions or saying, here's the problems, or, the parent, talking. And then, you get halfway through the session and then you're trying to figure out, okay, what do I even need to do during the session?
Right, or you're getting texts on your phone from another crisis that's going on, right?
Yeah. So really just being able to help slow down and be mindful in the moment of, even if you just spend a few minutes, but making sure that you are taking that moment to prepare for the session that you're going into or the service that you're about to provide, I think is also a very helpful part of that process.
In my book on quality control, in the introduction there, I share that like I was in 10 years practice, you guys, clinical practice, where I didn't routinely assess fidelity or IOA. And so I just made assumptions about the data that I was making database decisions about, and of course I watched my technicians run the programs and made decisions in the moment based on, am I seeing them implement something that looks like, yeah, that looks right. Like I have a way of controlling quality, so to speak. When I came out of academia, having been trained so much in single subject design and having a research program and getting really, really good at noticing when my decisions, my interventions, my protocols that I write, is it true? Is it true that they're responsible for my clients meeting their goals or making progress or behavior change? Is that real? And how good can you get out of a lab and into the real world and communities, homes, grocery stores, libraries, parks, and families' homes and daycare centers at controlling enough of the therapeutic environment where you can capture causal evidence with single subject design and, using fidelity and IOA to causal evidence that your intervention really is having that effect in the real world, because it's hard to put scientific methods into the real world with real people, you know? And so at some point, when I went back to practice after being a professor, there was a lot of variability in the graphs, and I was like, here's the deal. I gotta say goodbye. I am either going to quit and never ever be in a clinical role again, or I'm going to figure out how to routinely assess fidelity in IOA in every single session, anywhere, anytime, any system, any process, in any capacity with any client who I'm responsible for doing, like providing ABA. I've got to figure out how to do it. Because system imperfections and systems are absolutely everywhere. You cannot get away from it. You must accept that you work in imperfect imperfect and systems. And you may even get lucky and score and get in an organization that is investing everything they can into improving their systems and appropriate KPIs and monitoring systems and feedback loops and standards and all the things. And they might even like practically be going broke because they're spending so much time trying to improve the conditions, you know? And even there's going to be barriers. So you better figure out how to do this, do ABA everywhere, anywhere, anytime. That was my mindset. And I was like, if I can't, I'm out. I don't want to waste people's time. I don't want to live a lie and like report on treatment outcomes that are bogus or that I haven't personally verified with a certain level of my personally defined standard, whether I was responsible for that or if that just happened and I got lucky as a practitioner and now I get to look great that my client improved over 6 months. That's wrong. You know, I feel strongly about that.
So, okay. So when we're talking about that self-management practice, let's say, and we're looking at, okay, so we're talking about a BCBA and the traditional sense, the 2-tier model, they're, you know, supervising an RBT and, you know, doing all the clinical work for the learner. But what, and so I think in those roles, even if you come into a job with maybe poor communication of expectations, you at least somewhat know what's expected of you of a BCBA. It might not be a full encompassing or a great expectation, but you have a general idea of the main pieces that you need to do, right? But what about, it may be even a tech too, but what about the leadership of the company, you know, the clinical director, the, you know, managers and HR and billing department and all the other people that make up an ABA agency, right? Something that we see actually quite a lot is Azure. Okay. So you start as like a single BCBA, small company, right? And Stephen already spoke to it a little bit earlier. And then like you're in that level 1 and then you find yourself still in that level 1, 3 and 4 years in, and you've grown really fast and things are out of control, right? And in that process, you've hired, okay, fine. I have to delegate. I'll hire you to do this. I'll hire you to do this. I'll hire you to do this. And then finally it comes to the point where you realize, okay, things are really messy here. And so the meat of this is like not having clear expectations for the BCBA, for the RBTs. Yes. But also all of the other roles within the company, like help me connect that importance of having those clear expectations to being able to do the self-management practice and to be able to be responsible for quality within your role.
I think, I hear expectations and think standards, because if someone has an expectation of your performance, they've defined what good looks like, and they're presumably, and then so the question here becomes, how do you engage in practices where your performance meets their standard, meets their expectations? So I say that because if you equate standards with expectations, that gets you right back into the ASDQ framework and stuff, you know, of trying to, So I would say, I don't know if I'm answering your question here. I might lose it, but I would say like, if you're, let's see if we get this right. It's like if you're a level 1 or a level 2. So for audiences or a reminder, level 1 is like, you're a very small practice, you're a startup, maybe you're 1 or 2 years into it or something. There's a clear definition of quality in your organization. Supervision practices vary widely. decisions are based on perception. You're starting to make data-based decisions. You're starting to do that better. But what you probably realize is that you haven't been monitoring, and your data aren't what you thought they were. Or maybe your data aren't as valid, accurate, reliable, or cost efficient, and then it's hard to make data-based decisions. I think this will lead us into another triad. Okay, we didn't get to this before, but there's another, there's a framework that helps maybe contextualize and help us think about your question, which is a quality assurance, a model of quality assurance in human service settings that was developed by, or from chapter 2 in a book by Bradley and Bersani. And do I have the book around here or remember the title? I don't, but we'll put them in the show notes, I suppose.
Sure.
Okay. So we'll put it in the show notes. And their triad is standards, monitoring, and response mechanisms. So if planning, control, and or let's say professional consumer standards and financial health are a big old like umbrella framework within which to pursue quality assurance and build quality assurance systems, planning, control, and improvement are the principles you apply to attain standards in that framework. The same way we apply principles of reinforcement and punishment to establish behavior change. Well, you have a desired goal, right? You have a standard for what that behavior should look like. And so it's the same idea here. Okay, so you apply principles of plan, control, and improvement. And now that's think of it as the engine. Now, I think when we talk more about standards and meeting expectations, we should talk now about the what, the how of quality, which is standards, monitoring, and response mechanisms. So your standards, again, specify how well what good looks like. And so you can specify that for any role, any responsibilities, any organization. But then you have to have monitoring systems in place that measure indicators of whether those standards are attained. But not all standards are the same. So the Bradley and Bersani, and I wish I had this stuff memorized, but I don't. But people who go to that chapter 2, we'll see Bradley and Bersani define like 5 or 6 indicators of a suitable standard. An example can be, is a standard clear enough that anyone can read it and understand it? That means engage in behaviors that are specified by the standard. Maybe another criterion is a standard flexible enough that it allows an organization and its employees to deviate from the standard when it's appropriate and necessary, because sometimes it is. And then, so that framework provides someone a list of criteria to evaluate, are standards suitable for what we're trying to accomplish? And then the monitoring is about, are your data, are you spending, you should ask questions like, are you spending too much money to collect data on the practices that are related to the standard? Like, are you investing too much time or labor to justify the results or the decisions you're able to make in practice to improve performance? Another one is measurement valid? Is it reliable? Can it be automated? But right now it isn't. Do you have inter-observer agreement on data collected in a monitoring system? Now, if your standards are suitable and your monitoring system is valid, reliable, accurate, cost efficient, predictable, now you have the right data and you can start making decisions in feedback loops. You have response mechanisms, contingencies to improve performance. And so that's where I go when I think about some expectations. I think it's really, it's tough to expect people to meet your expectations if, as a leader, you haven't yet designed a system with valid suitable standards, valid monitoring systems, and feedback loops that gives the right information to the right people at the right time to allow an adjustment that's meaningful.
Yeah. Probably the main expectation of a BCBA for many practices is you get your 20 to 25 billable hours a week, right? Like that's it. Do you know what I mean? It's not anything on quality of life. It's not anything on, it's just, I need you to make this amount of money so that I can financially continue to grow this company. And it's, a certain level of profit, right? And because I know when I talk to many BCBAs, it's like the only focus is on billable hours, right? And that is the only expectation is, so.
But it doesn't have to be.
And so I think that goes back to the meaningful outcome, right? Where you were talking earlier, do you feel that that's a skill that most BCBAs have, that they can measure an effective outcome? Does that come natural to most BCBAs, or is that a gap in training?
Maybe the average, or every behavior analyst should have someone helping them ask that and answer that question. Which is and that's no new advice. It's have mentors and and friends and colleagues and be vulnerable and be open about your practice and the decisions you make in your thinking, and let people give you feedback on it, to tie back to what you were saying earlier, April, so that you can discover that, because there's going to be, anything's variable, right? There are probably plumbers who can't evaluate how good they are,
of course,
doing their job or whatever, And so I would say absolutely not. That wouldn't come naturally to any or most people probably, and therefore is helpful to do. But you know what? If your behavior analysts are trained to do things like task analyses, composite component analyses, to observe others and their own behavior and break it down into measurable chunks, and so if self-management doesn't come easy or come natural, or even monitoring, even if it's hard to say, I'm going to go into my protocol mod session today and I'm going to do one protocol mod, and I'm going to assess IOA on any challenge and behavior that occurs. I'm going to answer the technician any questions they have and try to eliminate barriers for them. And I'm going to do my SOAP note before the end of the session. Even so much can happen, especially in home, I would say, that the person, it doesn't come natural to everyone to even be able to remember, wait a minute, I'm supposed to be looking at that list I planned, and I'm supposed to click boxes or check things,
right.
And so what I would say, I love this saying of eat an elephant one bite at a time. It's it's anything that feels overwhelming or you're underprepared and you know that, and that's where the vital few concept comes in. I think is helpful to folks regardless of their career. I even apply that to my role as a dad, other identities I have, a dad and a husband and all the community member and all these things. I think I can only do a few things well, but so let's make sure I focus on those, and maybe one of your vital few is to, if you're a new BCBA trying to self-manage and you're noticing that you're having trouble with that, your vital few is to reach out to somebody who can help you, and maybe your vital few is be vulnerable and be open. Show who you are and what you got and what you're about. Don't hide nothing. Maybe that's your vital few. Don't hide.
Yes.
Honesty. Yeah.
You will be surprised how people will embrace you and take care of you and help you.
Yes. If you did not take anything else from this conversation, that's the piece that please walk away with, right? Because it really is, we're all human. And I say this all the time, right? That we really truly are human, and we're humans working in a human field. And there are so many variables, and we're bringing with us our whole selves too. Sure. And so are everyone that we're working with, and the families that we're working with, and the individuals that we're providing services for. There's a lot going on here when you're in a human service field, right? And so yes, be open, be vulnerable, be curious, right? Absolutely.
And so the app, is that for BCBAs just doing their own thing? Is that what you would recommend for them?
I think it's an excellent starting point. The tool won't be useful or reinforcing to everybody,
Sure.
And, anyone can pick up a notepad and plan and monitor the outcomes of their session. But we all use apps readily, and they have a strong influence on our behavior. And if you need, we've also designed this app with notification settings, and so that it might help too. It's like your notepad in your Excel file are not going to notify you, okay? But if you have an app that you can click settings like ours, then in the beginning of your day or before a session, you can plan it. And then you implement the session. At the end, you can set it up to get a notification at the end of the day. It says, hey, you had planned some outcomes. Don't forget to track them today, and then track your win too. Because I don't know, you guys, I can't live my life without technology reminding me of very important things, like I have going to a personal trainer tomorrow because I can't keep my butt in the gym and my body's getting old. And so, hallelujah, they have a system that just texted me, an hour ago, says, do you know remember your appointment tomorrow?
Right. Great.
What am I, a wizard? I can't keep track of everything. So I'd say rely on the app. Don't go caveman style and make markings on a wall, or use technology. I know you got 1,000 apps on your phone, 1,000 systems you navigate, but this isn't the world. This is the world today. So we have to adapt.
Yeah, for sure.
And then organizations, if they're okay, I want to implement a quality system. I want to do it well. This is important. I can see that. How do they what would be the point of contact to reach out to you? Where would the starting point be so that they can start this journey?
Yeah. Any organization wants to learn more about, what NASQN has to offer and how to help organizations or individual practitioners, because we are a professional association. So our mission is focus on ABA professionals in general. Okay. But guess what? The leaders at the top of organizations, they're ABA professionals, right? Okay. So, but I would say the best way to reach out to us is to email me at bsilbaugh@nasqn.org. I'm sure that'll be in the notes. NASQN's, website. We have a contact form there as well. Subscribing to our newsletter. And following myself or NASQN's LinkedIn page. I think those are really great ways to stay connected and reach out to us. We have other, ways to help ABA professionals we haven't talked about today. And also we learn. So the more that people reach out from us and tell us, where are you at in your journey in expanding on your your repertoire, your quality assurance repertoire. How's your professional development within the domain of quality assurance, quality planning, quality control, quality improvement, have you considered maybe getting a certification in Lean Six Sigma, where you can learn a whole set of quality methodologies outside the field? How do you do that? Who do you go to? Who knows about that? Well, we have people who know about that. We've got a member of our executive team who's Lean Six Sigma certified. And so anyway, so yeah, we learn, and NASQN was designed to promote a more empirical approach to quality assurance throughout the ABA industry to sort of address what I think, is a turning point in the field. And, any, I would say discipline or service or field or whatever, just like organizations, just like people, they develop, they evolve, they grow, they mature. And we're in our infancy in terms of a field like the practice of ABA, And I think that's where we're at. We're at a turning point where it's time that we should, and that's we believe it's time that we really shift from a focus on access to a focus on what people are getting access to.
Right.
It's the access to high quality services, because access alone is really
not enough.
Short. That's not actually what anybody needed. They need access to services that work.
Yeah. Access to terrible services is not helping anyone. Yeah. And then I think you all have a job website too, right?
Yeah, we have a career center, and the vision for the career center is that it connects ABA professionals who are really passionate about quality. Maybe they're pursuing Lean Six Sigma certification, like trying to expand on their professional development repertoire and quality assurance. They're members of NASQN, folks who want to find employers who are building systems and processes and have standards in place, who are maybe, and it was really about like trying to connect job seekers with employers on quality at the right stage for both of them. Okay. So it's like, someone who's really skilled in quality assurance in ABA, they might get real excited about connecting with a level 1 or a level 2 organization to help lift them up and help them take leaps ahead in what they're doing. But there also may be behavior analysts who really want to land in a level 4 or a level 5, and so all of that isn't really like clear or built out in the career center. That's more like the long-term vision, is make that a trusted source or hub where people who are job seekers and employers who are really focused on quality connect. And I believe that it's safe to say that most of the people who go to that career center are job seekers who are focused on quality, and therefore that's different than posting on a different career center or job board where you're going to get a wide variability in who's looking at your job descriptions and postings. So thank you, Steve, for asking about that.
I think it's important, right? Because if we can, we're kind of pointing the people in the right direction, right? And so if company leaders have incentives to go and find a quality person, right? They know that, okay, if I go here, I'm going to get who I need for this role. I think that will be helpful to everybody. So yeah, I love that idea. I think as the owners of the company go through this, it may even elicit some questions. Oh, I didn't even think about that. Well, let's have a further conversation on that. Right. And so, yeah, I would urge everyone to, at least go to your website, but try out the app, go to the job website. If quality is important to you, I think that's great. So
thank you so much.
Yeah.
Oh my goodness. I got so much out of this conversation today. I'm so excited. I could definitely continue talking for longer. I have many more questions in my head. I don't know. Maybe if we're lucky, maybe Bryant will come back on another day to continue the conversation.
Yeah, absolutely. Love to.
Oh, great. So all of the links, all of the things that we talked about today are in the show notes that if we don't already, we'll make sure to get the, how to access the app, and put that in the notes as well. Mm-hmm. Thank you. Thank you for such a great conversation today, Bryant. I really appreciate it.
Thank you both. Pleasure being with you. And, I hope we can do it again. This was awesome.
Absolutely.
All right, guys, those of you who are listening, thanks for being here today. Yeah. And we look forward to seeing you next week.
See ya.